Greetings, everyone, and welcome to the Deep Dive. Today, we are immersing ourselves in a topic that really sits at the crossroads of, well, classical philosophy, art, and some pretty cutting-edge clinical science. We're talking about the aesthetic blueprint of the human face. Our mission today is maybe a bit ambitious. We want to move beyond that simple idea that, beauty is just subjective. We're going to dive into the hard mathematics behind it all. Things like vertical and horizontal ratios, specific measurements, those sort of canonical proportions that seem to underpin what we perceive as facial harmony. And look, for clinicians out there involved in complex restorative work, orthodontics, or aesthetic reconstructions, these numbers aren't just nice to knows. They are basically the essential language of success. We'll analyze how face height, lip position, even dental alignment, how they all contribute to this harmony. And we'll provide some key numbers and insights that are really essential for comprehensive patient care.
Absolutely. This is such a crucial topic because the foundation, really the bedrock of any successful outcome in facial treatment starts with the diagnosis. And that diagnosis, it begins with aesthetic measurement. Cicero put it so well, everything is in the face. When you're diagnosing any facial or dental facial deformity, the process just has to be systematic. It needs to blend sort of the discerning eye of an artist, someone who understands proportion and symmetry with the, let's say, rigorous, methodical mind of a scientist. Because if we don't have that accurate diagnosis, honestly, the most exquisite technical skill in the world becomes, well, functionally useless. You're just treating without a proper map.
That's a really strong point. Diagnosis first, then the hands follow.
Precisely. And this integration, this fusion of art and science, it's really the fundamental theme running through all of facial aesthetics. You just have to look back to the Renaissance, right? Figures like Leonardo da Vinci. I mean, he lived and breathed this synergy. Da Vinci didn't just, sketch bodies beautifully. He dissected them. He measured them meticulously. He applied geometry to his observations. He seemed quite passionate about the idea that artists needed scientific methodology to achieve truly accurate representation. And conversely, the scientists needed the kind of observational tools of the artist to really perceive the complexities of the human form. It was a two-way street for him.
That's a powerful idea, isn't it? That scientific rigor actually elevates art, and having that artistic perspective can really sharpen the scientific approach. So in the clinical setting today, our sources, they lay out a pretty comprehensive approach to facial analysis. It relies on what are often called the 6 pillars of evaluation. Could you maybe quickly outline those 6 points for us? And then perhaps we can, zone in on the ones that are most crucial for, say, restorative work.
Certainly. Yeah, the 6 pillars give us a framework. They really range from the very large scale, the overall picture, right down to the minute details. Typically, they include, first, the profile, then vertical proportion, third is horizontal proportion, fourth, symmetry, fifth, soft tissue analysis, and finally, sixth, the dental component itself, the teeth and gums. The first one, the profile, which is essentially the sagittal view looking from the side. That's essential. This is where we determine if the patient has, broadly speaking, a convex face, a straight face, or maybe a concave facial structure. And that judgment is mainly based on the relationship between, say, the forehead, the position of the lips, and the prominence of the chin.
Right. And this profile analysis, that's generally more in the domain of specialized fields, correct? Like planning for orthognathic surgery where you might need major skeletal repositioning.
Exactly. Orthodontists and orthognathic surgeons, they rely very heavily on detailed cephalometric measurements, x-rays, tracings, all related to that profile view for planning big skeletal changes. But for many other dental specialties, general dentistry, prosthodontics, restorative work dealing with VDO or full mouth restorations, while the profile is definitely noted, it's the second pillar, vertical proportion, that becomes arguably the most critical and I'd say universally applicable element we really have to master day to day.
Okay, so this is where we take those maybe slightly intimidating, complex anatomical landmarks and actually translate them into a practical clinical rulebook. Because let's be honest, when you read a textbook, you encounter terms that sound quite academic, don't you? Landmarks like the subnasal.
The point right under the nose where the septum meets the upper lip.
Exactly. Or the menton.
The lowest point on the chin, yeah.
Right. They sound technical, but in the actual operatory, these landmarks become the defining boundaries for really practical procedures, don't they?
Precisely. Think about it from the perspective of the restorative dentist. When a patient comes in presenting with vertical dimension of occlusion, or VDO, loss, which is quite common, you see it with severe tooth wear, aging, maybe complete edentulosum. Essentially, the jaws have compressed vertically, the lower face looks shorter. The clinician in that case is basically rebuilding the architecture of that lower face.
Yeah.
And without objective, repeatable measurements derived directly from those landmarks, the subnasal, the menton, and others, that restoration becomes, well, just guesswork. It's artistry without the science.
Just kind of eyeballing it.
Right. And the success, the aesthetic and functional success, really hinges on understanding and applying those vertical ratios correctly. Okay, so let's really dive into those vertical ratios then. We should probably start with the historical standard, the one most people might have heard of. The classical canon of vertical proportion. It's known pretty universally as the rule of thirds. This concept, which was really championed by Da Vinci and other classical philosophers and artists, divided the face into 3 vertically equal segments. The ideal was considered a perfect 1-to-1-to-1 ratio.
Okay, so let's break down that 1.1.1 trisection just for clarity. Section 1, that goes from the hairline down to about the line of the eyebrows, right?
Correct. The trichin to the glabella, technically.
Got it. Section 2 then covers from the eyebrows down to the tip of the nose, or that subnasal landmark we mentioned.
Yes, glabella to subnasal.
And the third section, runs from subnasal right down to the bottom of the chin, the menton.
Subnasal to menton, exactly.
And for centuries, literally centuries, that 1.1.1 was the golden mean, wasn't it? The standard definition of ideal beauty, at least in Western art and thought.
That was absolutely the classical standard, yes. It served as a theoretical ideal, a benchmark, for hundreds of years. However, and this is a big however, this is where modern science, specifically the field of craniofacial anthropology, really enters the picture and starts to, well, challenge the pure art perspective. Starting mainly in the 20th century, you had researchers, people like Leslie Farkas was a big name, who began meticulously measuring thousands and thousands of actual human faces across different populations, different genders, various ethnicities, real people, not idealized drawings.
Okay, so what did they find? When they measured all these real, biologically varied human beings, how did the numbers compare to Da Vinci's perfect 1.1.1 canonical ideal?
Well, they found that the strict 1.1.1 ratio is actually quite rare in the general population, especially when looking at Western cohorts, which were often the focus of early studies. Biological variation consistently showed that the lower third of the face, that distance from the base of the nose down to the chin, the subnasal to menton segment, is typically, and quite naturally, longer than the upper or middle thirds. Basically, the 1.1.1 ideal makes the lower face too short for most average individuals we see today.
Wow, okay. That's a really significant finding, isn't it? So if a clinician were to adhere strictly, religiously to that ancient 1.1.1 model when defining, say, a new vertical dimension for a patient, maybe someone who's lost VDO, they actually risk making the patient's lower face look visually compressed, or possibly even making them look older than they actually are.
That's exactly the risk.
Yeah.
You could inadvertently create an aesthetic that isn't harmonious with modern biological norms. It might look off without the patient or even the clinician knowing exactly why.
So what are the specific modern anthropological adjustments we should be aiming for then? If 1.1.1 is out, what's in?
We need to account for that subtle but consistent elongation of the lower third. The data varies slightly depending on the population studied, but generally accepted average ratios for males shift to approximately 1.2.
Okay, 1 to 1 to 1.2 for males. So that 0.2 increase, that's the key difference in the lower third.
Precisely. And for females, the variation is often observed to be slightly different again, roughly 1.1.2.
Ah, interesting. So for females, the middle third, from the brow to the nasal tip, that sometimes gains a little proportional advantage over the upper third, but the lower third still remains the longest component overall at 1.2.
That's a common finding, yes. The middle third might be slightly longer relative to the upper third in females compared to males, but that lower third elongation to around 1.2 holds fairly consistently across both sexes in many populations studied.
These subtle shifts, especially that 1.2 factor, really demonstrate why just, eyeballing aesthetics isn't enough. It's deceptively complex. When you are essentially the architect of a patient's new face height, like when you're increasing VDO by maybe several millimeters, you have to ensure those millimeters are proportionally allocated. They need to meet this anthropological norm, not just the old philosophical ideal.
Precisely. It's about restoring to a biological average, not an abstract concept. And the detail doesn't even stop there. We need to zoom in even further on that crucial lower third, that 1.2 segment we just talked about.
Right.
Because this region is largely defined by the soft tissue surrounding the mouth, crucially, the lips. And within that 1.2 lower facial third, we have his own unique set of critical vertical proportions, Specifically, we're talking about the height of the upper lip relative to the combined height of the lower lip and the chin.
Okay, so a ratio within the ratio. What were the classical ideas about this lower third division, and how has modern science adjusted that view as well?
Well, some older dental texts, they might have cited divisions of the lower third based on lip and chin height. You might see references to maybe a 1.3.2 ratio in some very early descriptions, breaking it into upper lip, lower lip, and chin separately. But honestly, those often lack precision or strong anthropological backing. The modern anthropological consensus, which is incredibly critical for defining things like lip support, tooth display, and overall aesthetics, finds that the ratio is closer to 1 to 2.3.
1 to 2.3. And what does that represent exactly?
That's comparing the upper lip segment measured vertically from the subnasal down to where the upper and lower lips meet, the stomian, against the lower lip and chin segment, which runs from that lip junction, the stomian, down to the menton. So putting it another way, this means the upper lip typically makes up approximately 40% of that total lower face height, from subnasal to menton, and the combination of the lower lip and the chin makes up the remaining 60%.
Right, okay. So we're essentially talking about a 40-60 vertical split within that lower third of the face. Why is achieving that specific 40-60 split so challenging sometimes, and yet, as you say, so crucial clinically?
It's challenging because it involves managing both hard tissue, like tooth position and alveolar bone, and soft tissue, the lips themselves. And it's crucial because it really dictates the appearance of youthful lip fullness, proper projection, and natural tooth display. When we're reconstructing VDO or even just designing anterior restorations, if we fail to respect that 40-60 division, maybe we make the upper lip area too short vertically, or perhaps too long in proportion to the lower segment. The resulting smile can look unnatural. It might look strained, the lips might look thin or unsupported, or perhaps the patient gets that slightly pushed-in appearance around the mouth. That's often a hallmark of poor lip support or miscalculated vertical dimension.
I see. So getting that 40-60 proportion right is really the difference between a restoration that's just functional or maybe acceptable and the one that looks aesthetically stunning and completely natural.
Absolutely. It's one of those fine details that separates good work from great work. Mastering the 40-60 rule in the lower face is key.
Okay, that deep dive into the vertical dimension really shows how much geometry guides both the macro and the micro proportionality of the face. It's quite fascinating. But now we have to address the orientation, right? I mean, it doesn't really matter if your vertical proportions are technically perfect if the whole structure seems tilted on the face. Which brings us, I think, quite seamlessly to the next critical concept, horizontal parallelism. This is the idea, or maybe the mandate, that these transverse lines across the face must align properly to create what our sources call the cohesive force, or basically harmony.
Cohesion is exactly the right word. You can have perfectly proportioned teeth, beautiful restorations viewed in isolation on a model. But if they violate the key horizontal references of the actual face, the whole thing will fail aesthetically. In our diagnostic sequence, we really focus on 3 interconnected horizontal references. Crucially, their relationship to one another is pretty much non-negotiable for a good outcome.
All right, let's define those 3 key lines then. So first we have the interpupillary line, right? That's the line connecting the centers of the pupils.
Correct. A fundamental horizontal reference.
Second, we have what's historically been called the incisal plane. That's the line touching the cutting edges of the maxillary anterior teeth, the upper front teeth.
Yes. Traditionally conceived as a straight plane.
And then third, related dynamically to the others, especially during function, is the smile arc.
Exactly. The curve of the lower lip during a smile. Now, the primary clinical rule, the one that's paramount, is that the interpupillary line and the incisal plane must be parallel to each other. This rule seems to hold true regardless of gender, age, or ethnicity. It's a universal aesthetic principle. If that incisal plane is tilted, canted up or down relative to the line of the eyes, the resulting asymmetry is almost immediately recognized by the human brain as, well, disharmonious. It just looks wrong.
Okay, that makes intuitive sense. But how do clinicians, especially those dealing with, say, removable prosthetics like dentures or maybe large fixed cases spanning the whole arch, how do they ensure this parallelism isn't just guessed at, but is accurately measured and transferred in the operatory?
Right, because just freehanding it is very risky. We use specific tools and techniques. In prosthodontics, for example, the classic tool is often the Fox plane.
Ah, yes, the Fox plane. Looks a bit like a metal spatula with wings.
Kind of, yeah. It's an intraoral plate attached to an extraoral frame. It helps the clinician visualize and orient the occlusal plane, usually represented initially by a wax rim in the patient's mouth relative to other facial landmarks. We also use specialized articulating frames, sometimes coupled with mechanical face bows. These instruments are designed to help transfer the plane of the eyes, the interpupillary line, accurately onto the dental models back in the lab or onto the wax rim directly in the clinic.
So you're using visual references, maybe bubble levels or horizontal markers that are actually integrated into these instruments.
Exactly. The goal is to ensure that the wax rim, which is the blueprint for where the teeth will eventually be set, mirrors that interpupillary line perfectly parallel. It really is an engineering task, but it's applied directly towards achieving an aesthetic goal.
It sounds quite precise.
It needs to be. And we actually have some compelling statistical evidence that supports this strong aesthetic preference for parallelism. The sources cite a really interesting paper that came out of Brazil.
Brazil, okay.
Yes, and we shouldn't underestimate their contributions. Brazilian researchers are actually very strong in dental aesthetics research. This particular study looked at 102 dental students.
Okay, 102 dental students. What did that study reveal about their natural alignment? How common is this parallelism naturally?
Well, the results were quite striking. It revealed that a stunning 0% of the participants naturally exhibited perfect or near perfect parallelism between their interpupillary line and their existing incisal plane.
70%.
Yes. And conversely, only 30% showed a perceptible degree of non-parallelism, a noticeable tilt.
That 70% figure is pretty profound, isn't it? It strongly suggests that this parallelism isn't just some arbitrary aesthetic concept that dentists invented. It seems to be the natural anatomical norm for the vast majority of people.
Exactly. And therefore, it becomes the universal aesthetic expectation. Our brains are likely hardwired to see parallelism as correct or harmonious because it's what we most commonly encounter.
So here's a clinical question then. If we're treating a patient and maybe they fall into that 30% who exhibit some natural non-parallelism, are they inherently less attractive because of that? Or does that statistical deviation demand a specific treatment approach from us?
That's a great question. It definitely demands a specific treatment approach. While a very slight degree of natural non-parallelism might be present and perhaps aesthetically compensated for by other positive features in the face, the clinical goal in restorative or orthodontic treatment must always be to restore towards that 70% ideal of parallelism. Especially in full mouth reconstruction or comprehensive orthodontics, we're often given this unique opportunity to correct that deviation entirely. If we fail to establish that parallelism, if we build in or accept a tilt, we essentially guarantee a visually flawed result from the outset. That tilt, or what clinicians sometimes call the canted occlusal plane, is just extremely jarring to the eye. It screams artificial or incorrect.
Okay, so always aim for parallel. But, concepts in dentistry are always evolving, aren't they? We've been discussing the incisal plane as if it's this static, perfectly horizontal straight line. But the sources note that, particularly post-2000, there's been a significant conceptual shift, driven largely by orthodontists, I believe, moving away from the idea of a plane towards thinking about an arc.
Yes, that's a very important evolution in thinking, the incisal arc concept.
What does this shift from a straight plane to a curved arc imply for our treatment planning and aesthetic goals?
It implies aiming for dynamic beauty, not static rigidity. You see, the traditional term incisal plane suggests a ruled or straight line connecting the incisal edges of the upper front teeth, maybe from canine to canine. But the modern understanding, really pushed forward by aesthetic-focused orthodontists and prosthodontists, recognizes that the hypothetical line connecting these cutting edges isn't, or perhaps shouldn't be, perfectly straight in an ideal smile. It's actually a gentle curve, an incisal arc.
An arc. Okay, and how does this arc relate to the face?
Critically, this arc should ideally parallel the curvature of the patient's lower lip when they produce a natural, spontaneous smile. That's the key relationship.
Ah, I see. So it's not just about being parallel to the eyes anymore, but also about harmonizing with the shape of the smile itself.
Exactly. This is a crucial functional and aesthetic detail. Think about it. If a restoration creates a perfectly flat, horizontal incisal plane, like a tabletop, when that patient smiles, the gap between the curve of their lower lip and the straight line of the teeth, what we sometimes call the negative space, can become exaggerated or uneven. It can create a kind of static, maybe even artificial or denture-like appearance.
Right, it wouldn't look integrated.
Precisely. But by designing an incisal arc that typically dips slightly downward from the canines towards the central incisors, following the natural curvature of the lower lip, we achieve what's often called the consonant smile. Consonant meaning in harmony. A smile where the curve of the upper teeth beautifully complements the curve of the lower lip.
So focusing on the incisal arc ensures the restoration looks harmonious, not just when the mouth is at rest, but also, crucially, when the patient is expressing joy, when they're actually smiling.
That's the goal, dynamic harmony.
Okay, so we've successfully mapped out quite a few objective, quantifiable aspects of facial beauty, haven't we? We've got the vertical 1.1.1.2 ratio as a modern guide, that critical 40-60 lip split in the lower third, and the, well, 70% mandate for horizontal parallelism between the eyes and the teeth. These are solid geometric principles. Yet, even with all these measurements and ratios nailed down, we're still left with that great philosophical question, aren't we? Why ultimately do we find one face beautiful and another perhaps less so, or even unattractive? The true definition of aesthetic preference seems to remain something of an enigma, something that maybe transcends pure geometry.
It certainly does. And this brings us right back to that classic historical debate we touched on earlier. Is beauty fundamentally objective? Is it determined by inherent measurable qualities like these ratios and geometric forms we've been discussing? Or is it purely subjective? Does it truly exist only in the eye of the beholder, as the famous phrase, popularized by Margaret Wolfe Hungerford in the 19th century, suggests?
Philosophers have really wrestled with this for millennia, haven't they? You mentioned David Hume, the empiricist, who argued pretty strongly that beauty rests entirely in sentiment or taste, implying it's totally subjective, dependent on the individual observer. But then you have other thinkers like Francis Hutcheson back in the 18th century who countered that. He argued that aesthetic judgments actually rely on a kind of sense that is common to all, an intuitive thing.
Right. Hutchison suggested there's an almost intuitive element, something that doesn't necessarily require conscious reasoning or measurement, but is somehow shared across people.
So why should a busy clinician, focused on margins and materials, care about 18th century philosophy on beauty? How does this objective versus subjective debate actually play out clinically?
Well, I think it frames the clinical dilemma we face almost every day. Our sources rightly highlight that this whole debate about subjectivity, it really only applies intensely to faces that fall within normal limits. Think about it. No one seriously argues that a severe skeletal deformity, like a major jaw discrepancy or significant tissue damage, is somehow beautiful in a conventional sense. Those deviations are pretty much universally recognized as needing correction, as being aesthetically off.
Okay, that's fair. So the disagreement, the room for individual taste and subjectivity really emerges when we are dealing with faces that already adhere, more or less, to that 1.1.1.2 norm, that have decent symmetry but still carry subtle variations, those individual differences.
Exactly. It's within that broad spectrum of normal where cultural influences, personal preferences, and maybe even fashion trends start to play a much bigger role in defining what's considered currently attractive or desirable.
All right, let's maybe pivot back from philosophy towards the hard science again. What are some of the leading evolutionary or psychological theories that attempt to quantify or at least explain this aesthetic preference beyond just simple ratios? What else is going on?
Well, probably the most famous and intriguing theory is the averageness hypothesis. And it actually has a wonderful, almost accidental origin story involving Sir Francis Galton back in the late 1800s.
Galton. He was Charles Darwin's half-cousin, right? And quite obsessed with eugenics and criminology, unfortunately.
He was indeed. And his initial goal, using a very pioneering technique at the time called composite photography, where he overlaid photographic negatives of multiple faces, was actually to isolate the common features of deviance. He literally wanted to find the typical criminal face.
So he took photos of dozens, maybe hundreds of convicted criminals, layered them up, thinking he'd see the ultimate face of evil or degeneracy emerge from that blend.
That was precisely his hypothesis. He thought the average would reveal the undesirable commonality, but the result was the complete opposite of what he intended or expected. When he composited 20 or 50 or even 100 individual faces together, the resulting average composite face was consistently judged by observers as being more attractive, often significantly more attractive, than almost any of the individual component faces used to create it.
That is genuinely fascinating irony, isn't it? He failed spectacularly to find the face of the criminal, but accidentally stumbled upon the face of average beauty.
Pretty much. He inadvertently provided strong evidence for the averageness hypothesis. The theory essentially posits that we humans are instinctively, perhaps subconsciously, attracted to facial features that represent the mathematical average of the population we're familiar with.
And why would average be attractive? What's the evolutionary thinking there?
The term sometimes used is koinophilia, which basically means the love of the average or love of the common. Evolutionarily speaking, average facial features are thought to signal a high degree of genetic fitness. They suggest a lack of potentially harmful genetic mutations or developmental anomalies. They imply heterozygosity, maybe a robust immune system. Average features signify normalcy, familiarity, and biological stability.
So our brains might be wired to see average as healthy and therefore desirable.
That's the core idea. This instinctual preference for the average, which inherently smooths out any extreme or unusual features and irregularities, helps explain why those composite faces, which are literally the mathematical average, often achieve the highest aesthetic ratings in studies.
Okay, that makes a lot of sense. Now, what about symmetry? That's the other big one we always hear about. Symmetry equals beauty, right?
Well, yes and no. Symmetry is definitely important, and like averageness, it's also considered a marker of developmental stability and genetic health. Asymmetry can sometimes signal illness, injury, or genetic issues. However, rigorous studies looking at perfect computer-generated symmetry often show something surprising. Perfect symmetry is actually often rejected by the human observer.
Rejected. Why would perfect symmetry be unattractive? That seems counterintuitive.
Because it can look unnatural, maybe even slightly disturbing or uncanny. When researchers take a photograph of a real face, digitally mirror one half of it perfectly onto the other side to create a mathematically flawless symmetrical image, and then ask subjects to rate the attractiveness of this perfect image compared to the original, slightly asymmetrical face. The perfectly engineered symmetrical version is frequently rated as less attractive.
Huh. So we're not actually looking for absolute mirror image perfection then. We're looking for harmony and balance, yes, but maybe not that kind of rigid mathematical perfection we prefer. Normal, subtle asymmetry.
Precisely. Normal, slight asymmetry seems to be the preferred marker of a natural, biological human form. The pursuit of mathematically perfect bilateral symmetry in clinical treatment, while maybe seeming logical, can sometimes lead to a result that feels too rigid, too artificial, or manufactured.
Like it lacks life or character.
Perhaps, yeah. Our aesthetic sense appears to be finely tuned to recognize and even appreciate the subtle natural deviations that mark individuality, as long as they exist within the broader confines of overall balance and those proportions we discussed earlier.
Okay, so averageness and normal asymmetry are key factors. Are there other evolutionary markers that the science suggests contribute to perceived beauty?
Yes, a couple more are worth mentioning briefly. One is neoteny.
Neoteny, that refers to the retention of juvenile or baby-like features into adulthood, right?
Exactly. Sometimes called baby faceness. Features like relatively large eyes compared to the face, maybe a smaller lower jaw and nose, fuller lips. These traits correlate quite highly with perceived attractiveness, especially, though not exclusively, in women.
And the evolutionary thinking there is it taps into a deep, possibly hardwired, nurturing instinct.
That seems to be the leading theory. Evolutionary psychologists suggest these neotenous features might subconsciously signal youth, fertility, health, and perhaps lower levels of dominance, which could trigger protective or nurturing responses. Features that mimic infancy might leverage that basic human instinct. And finally, we really need to consider the role of instinct, or heredity itself. We talked about the cultural debate, whether beauty standards are purely learned, but research using infants really challenges that idea.
How so? What do studies with infants show?
Well, several studies have quite convincingly shown that infants as young as 3 months old, long before they've had significant cultural exposure or explicit teaching about beauty standards, already show a preference for gazing longer at faces that had been previously judged as attractive by adults.
3 months old, really?
Yes. They'll spend more time looking at the attractive face compared to the unattractive one when presented side by side.
That's incredible. So that suggests that the basic foundation for recognizing facial harmony, balance, maybe even some aspects of averageness, isn't purely learned from magazines or movies. It's likely, at least in part, genetic or hardwired into our brains from birth.
It certainly supports the idea that we are born with, at minimum, a rudimentary aesthetic sense, a predisposition to recognize and prefer certain patterns associated with health and normalcy. Culture then builds upon and modifies that foundation, of course, but the base seems innate. Hashtag outro.
Wow. This deep dive has really shown that clinical aesthetics is such a sophisticated blend of, well, history, geometry, anthropology, and even evolutionary psychology. It's fascinating. We've journeyed from the philosophical canons of Da Vinci's a 1.1.1 through the empirical data of modern anthropometry that gave us the 1.1.1.2 ratio as a better critical guide. We've detailed that critical 40-60 vertical split in the lower face and highlighted that crucial 70% mandate for horizontal parallelism between the eyes and the teeth. These really are central guideposts in our diagnostic process, aren't they?
They absolutely are. We rely heavily on these objective measurements, these quantifiable ratios, to ground our treatment planning. They give us a framework, a starting point, and help us achieve more predictable results for our patients. Yet, and this is the constant tension, we must always remember that specific beauty standards, the finer points of what's considered ideal, are fluid. They do evolve across cultures and certainly across generations. As we discussed, while severe deformities are pretty much universally recognized as needing correction, once we're within that vast normal range, personal preference, individual perception, and that subjective human intuition still hold enormous sway. So perhaps we can leave you, our listeners, with this provocative thought to ponder. If achieving truly successful, long-lasting facial harmony requires integrating both the objective, measurable data, the science we discussed, and the highly subjective element of perceived appearance, the patient's feelings, the clinician's eye, the art, which of these two elements, ultimately? The precise, quantifiable ratio or the observer's deeply rooted, maybe even instinctive, intuition? Which one do you believe ultimately carries more weight in determining true, meaningful treatment success for our patients?
That's a great question to reflect on that powerful, maybe sometimes challenging blend of art and science in everything we do. Thank you so much for joining us for this deep dive. Thank you for joining us on the deep dive. Bye bye. Silence for 1 second.